Hello, my name is Tejas Patil. I'm an assistant professor of thoracic oncology at the University of Colorado Cancer Center. And I want to thank everyone for tuning in today to learn a little bit about lung cancer. The title of my talk is We've Come a Long Way. And this is really for what patients and patient advocates need to know about lung cancer management in 2024. These are my disclosures. This is what we'll cover today. We'll do a little bit of background. We'll then talk about immune therapy. We'll talk about targeted therapy and some future directions for lung cancer research. So the major risk factors for lung cancer, even in 2024, continue to be tobacco smoke. There's about 50 different carcinogens in tobacco smoke that are nicely illustrated in this diagram on the right. It's also important to note that not just tobacco smoke from cigarettes, but environmental tobacco smoke or environmental tobacco exposure, largely through secondhand smoke and or biomass burning. And this is very relevant in developing countries where there's a lot of wood and coal usage, especially in kitchens. Air pollution has been linked to the development of lung cancer, and exposure to certain radioactive elements such as uranium, radium, and radon have been linked with lung cancer. Now, not everyone who smokes gets lung cancer, and it's a very important mantra of mine that if you have lungs, you can get lung cancer. There are certainly biological risk factors. Some of the most well-studied include solid organ transplantation. We know that patients who, for example, get a kidney transplant and are on chronic immune suppression have a very high risk of developing lung cancer in their lifetime. This is also true for patients who have HIV, even if the HIV is very well controlled for reasons that are not quite well understood. And the final point here is something called the field cancerization effect. And that's a complex term that really means that a prior history of a head and neck cancer or bladder cancer or lung cancer dramatically increases the risk for a subsequent cancer. And so patients who've had a cancer diagnosis really need to make sure that they're being followed and having regular CT scans to reduce the risk of a second primary. When we say lung cancer, there are different ways it can look like under the microscope, and approximately 1/4 or 25% of these will be small cell lung cancer. The remaining 75% will be non-small cell lung cancer, and the distribution of these is listed below, with adenocarcinoma being by far the most common subtype of lung cancer that we see in the United States and globally, although other subtypes are seen as well, which include squamous, adenosquamous, large cell, and sarcomatoid. Lung cancer is a major clinical problem. This is the NCI SEER 2021 cancer statistics. And as you can see here, lung cancer is the second most common cause of cancer in men and in women, but is the leading cause of cancer death in men and women. Historically, chemotherapy was the preferred option for lung cancer. And these are the variety of different chemotherapy options that could be used for patients with a new diagnosis of lung cancer. When we say platinum, it's a really specific type of chemotherapy. There are two choices. There's a drug called cisplatin and another drug called carboplatin. But all the old studies that have looked at chemotherapy combinations really have shown that doing chemotherapy is certainly better than doing nothing. That's what this diagram called a forest plot shows. And there's a favor towards using chemotherapy. The problem is, how much benefit are you really getting with chemotherapy? So this is also, again, reinforcing the prior slide, which showed that there was a benefit for chemotherapy. But when you look at the survival curves, and this is something we do a lot in oncology, is on the y-axis, you see probability of an event, in this case, survival. And on the x-axis, you have little indentations or marks that look at time. And while it's true that chemotherapy, which is indicated in the blue line, does better than standard of care alone, or supportive care alone in this case, the actual benefit at a 12-month mark, which is 1 year, is 29% versus 20%. So the ceiling of chemotherapy was a 29% improvement in 1 year survival. So the bar was already very, very low for lung cancer coming into all of this. And as I will hopefully show everyone in this talk, there have been really two major advances in lung cancer that have really dramatically changed this.